Welcome to eNormous Nephrology Volume 6. This YouTube channel, entitled eNormous Nephrology, started off as 8 sessions of board review. The idea was that we would begin with a discussion, an overall board review of all of nephrology, allowing the nephrologist or non-nephrologist to prioritize areas needing further study as that person progressed towards the boards or towards betterment in his or her clinical practice. This will be the 6th talk in the 8 sessions of board review. This is Nephritic Syndromes, Part 1. Board review talk 6 will be Nephritic Syndromes, Part 2, and we'll finish off the 8th talk with Nephrotic Syndromes. Board review talk number 5 focused on what exactly are nephritic and nephrotic syndromes in general, and a preliminary introduction to how kidney biopsies are interpreted and how they can be used in the diagnosis and management of nephritic and nephrotic syndromes. So one way to suspect if a nephritic syndrome is present is to become aware that the urinalysis has a combination of proteinuria plus hematuria. And if there's concomitant abnormal or downtrending GFR, then the suspicion becomes a little bit more potent. Then you should always begin with urine microscopy, and you'll be looking for red blood cell casts, dysmorphic red blood cells, and these were discussed in the board review volume number 5. So let's talk about IgA nephropathy. This is the most common glomerular disease. Its incidence is very high in East Asians and Northern Europeans, and low in people with sub-Saharan ancestry. The presentation can be simply benign hematuria, but most commonly it presents with hematuria with or without subnephrotic proteinuria. IgA nephropathy can present as progressive CKD or nephrotic syndrome with reduced GFR, and this tends to be aggressive disease on histology. And rarely, IgA nephropathy can present with concomitant minimal change disease. And IgA nephropathy vasculitis is what we know as Henoch-Schönlein purpura. Younger patients can present with gross hematuria in the setting of pharyngitis. But pharyngitis is uncommon in patients older than 40 years. And in the adult clinics, this presentation is relatively rare. As far as IgA nephropathy, one must distinguish it from infection-related IgA-dominant glomerulonephritis, because immunosuppressive treatment of IgA nephropathy can worsen staphylococcal infections. And staphylococcal post-infectious glomerulonephritis may have more endocapillary proliferation. Two-thirds of patients with IgA nephropathy have more than 1 gram of proteinuria at the time of presentation. 3/4 of patients present with renal impairment at the time of presentation. The course of IgA nephropathy can be fluctuating, and early benefit of therapy has been proposed. A subset of patients have persistent disease activity without clinical evidence of progression, and this can be for upwards of 5 years. And then a subset has rapidly progressive glomerulonephritis or crescentic IgA nephropathy. So what do we see on kidney biopsy? How do you diagnose IgA nephropathy? Typically, you will see mesangial proliferation, and dominant or co-dominant IgA deposits on immunofluorescence and electron microscopy. And then we'll talk about the MEST-C score, um, which includes quantification of mesangial hypercellularity, endocapillary hypercellularity, segmental sclerosis, tubular atrophy and interstitial fibrosis, and crescents, and how we use the MEST-C score to determine prognosis and how aggressive you'll be in your immunosuppression, if immunosuppression is warranted at all. And in the corner, I quickly have put in the interpretation of the quantification itself. All of these terms, mesangial hypercellularity, endocapillary hypercellularity, segmental sclerosis, interstitial fibrosis, and tubular atrophy, and crescents have been described in some detail in board review talk number 5. So this is an example of mesangial expansion. As you can see, the purple aspect here in the mesangium is a little bit more prominent. That's the mesangial expansion. And that mesangial proliferation implies that you have more than 4 cells in one contiguous area of mesangium. And you can see that in several areas, like here and over here. So there's mesangial expansion and mesangial proliferation on this slide. Endocapillary proliferation, as I explained in board review talk number 5, implies that the capillaries are not open. And by open capillaries, on kidney biopsy, you're going to see that capillary is wide open, and you're going to see basically a capillary with all white inside because there are no cells. Here, you can see that all the capillaries are not open because they're full of cells, and you see very little white in this area. So that's endocapillary proliferation. This is segmental sclerosis. You can see that there's sclerosis in the segment of the glomerulus. And this is immunofluorescence. So you have to know what was stained in the slide. And this was a stain for IgA. And you can see that the staining for IgA is relatively intense. This is mesangial deposits. So here's your cell, here's the mesangial area, and you can see the mesangial deposits in the mesangium. And then these are subendothelial deposits that you can see in IgA nephropathy. That's over here, the dark stuff here. And you can tell that that's subendothelial because you have the basement membrane, and then to the right of it are the podocytes, or the endothelial epithelial cell. So just below the podocytes will be the subepithelial deposits, and then to the other side of the basement membrane will be your subendothelial deposits. So back to the MEST-C score. Each feature is assigned a score, 0 or 1 for M, E, and S, and then 0, 1, or 2 for T and C. Higher scores generally indicate more severe kidney damage and a poorer prognosis. And this total score of 0 to 1 is associated with a favorable 10-year renal survival rate. Score of 2 to 4 represents an intermediate level of kidney damage with a moderate 10-year renal survival rate. And a score of 5 to 7 indicates the most severe form of kidney damage associated with the lowest 10-year survival rate and a higher risk of developing end-stage renal disease. So exactly what causes IgA nephropathy? In IgA nephropathy, circulating IgA1 and IgA1 in kidney deposits exhibit galactose deficiency in the O-linked glycans in the hinge region of the heavy chain. So the hypothesis is that the galactose deficient IgA1 autoantibodies form immune complexes which deposit in the kidney, leading ultimately to kidney injury. So the first hit is that you have increased galactose deficient IgA1 due to hereditary factors or plasma cell defects. And then we'll talk about how um, these aspects can lead to therapeutic innovations, and a lot of therapeutic innovation has occurred in the recent past, and we'll talk a little bit about that. So first step is that you have increased galactose deficient IgA1. And then you will develop autoantibodies to the GalNAc containing epitopes on the galactose deficient hinge region of IgA1. So now you have galactose deficient IgA, you have autoantibodies to the GalNAc containing epitopes, and then of course you're going to develop immune complexes, and those immune complexes will deposit in the kidney. And then once immune complex deposition occurs, the immune complexes will activate mesangial cells and induce proliferation and secretion of extracellular matrix, cytokines and chemokines, resulting in kidney injury. So that proliferation is when inflammatory cells enter the mesangial area or the endocapillary area, and then the secretion of the extracellular matrix is what gives you the mesangial expansion. 25 to 30% of patients report family history of kidney disease. So there probably is a inherited aspect to IgA nephropathy. Galactose deficient IgA1 are heritable, which means that the levels are higher in patients with IgA nephropathy and their first degree relatives compared to healthy controls or patients with other nephropathies. And genomic studies have identified 15 susceptible loci in the HLA region. The loci encode proteins involved in the maintenance of the intestinal barrier and regulation of the mucosal immune response to pathogens. And this is important because that is thought to be what contributes to the formation of these abnormal IgA antibodies, is that when that intestinal barrier is broken or that mucosal immune response is stimulated to certain pathogens. Asians do have the highest frequency of risk alleles, and Africans have the lowest. So there is some association between hereditary factors and IgA nephropathy. There is a strong relationship between the level and duration of proteinuria and loss of kidney function. So reduction in proteinuria is very important. It is associated with improved renal function outcome and death, and that's the major emphasis in IgA nephropathy, is to achieve those proteinuria goals, which in the past used to be less than 500 milligrams, and now is the goal is to achieve less than 250 milligrams over 24 hours in a 24-hour period. Increase in the degree of microhematuria is associated with renal function decline, and remission of hematuria is also important. It is associated with lower rate of kidney disease progression, although this is a little bit harder to demonstrate, and some studies have not demonstrated that. 4.54 cases per 100 person years develop end-stage renal disease in one study from Southern California. The mortality risk is also increased. In one study, IgA nephropathy was associated with one extra death per 310 person years. Although this risk may be limited to patients who actually developed end-stage renal disease and have become dialysis dependent. So, of course, proteinuria is highly important, and you want to start off with ACE and ARBs for proteinuria greater than 500 milligrams per day, and for blood pressure reduction. Although per KDIGO, you should treat to systolic blood pressure of less than 120 millimeters of mercury using ACEs and ARBs, and then use ACE-ARBs even in the absence of hypertension for proteinuria greater than 500 milligrams per day. SGLT2 inhibitors reduce proteinuria, sustain the decline in GFR, end-stage renal disease, or death from kidney disease-related or cardiovascular cause compared to placebo. So SGLT2 inhibitors should be used. Role of immunosuppression is not clear. The immunosuppression does induce clinical remission, which means proteinuria less than 250 milligrams per day, and GFR decrease less than 5 milliliters per minute per body surface area. However, there was no difference in progression between immunosuppression and supportive care, and there were more adverse events with immunosuppression. And upon 10-year follow-up, there was no difference between the groups in death, end-stage renal disease, or GFR loss of greater than 40%. So newer treatments include dual endothelin and angiotensin II receptor antagonists. Activation of endothelin A receptor promotes endothelial dysfunction, podocyte damage, mesangial expansion, and tubular inflammation and fibrosis. So it's thought that antagonizing endothelin will be important in achieving remission in IgA nephropathy. Targeted release budesonide is an important innovation in the treatment of IgA nephropathy. The age-old treatment for IgA nephropathy was prednisone, and of course prednisone works, but prednisone is a little bit non-specific. It works throughout the body and not just in the lymphoid tissue, where in the gut-associated lymphoid tissue, which is where the abnormal IgA antibodies form. So instead of having a non-specific approach to immunosuppression, it was thought that why don't we attack the gut-associated lymphoid tissue, which is highest in the Peyer's patches of the distal ileum. And that's what targeted release budesonide does. The targeted release budesonide is formulated to release the drug in the distal ileum, which is where the highest density of Peyer's patches is. And this approach targets the gut-associated lymphoid tissue and is specific, and may also be less associated with adverse effects. Iptacopan has been shown to have efficacy in IgA nephropathy, and this is a complement factor B inhibitor. Inhibitor of BAFF and APRIL, which is atacicept, and now some other formulations are also available, have been shown to be effective. So what exactly is APRIL? APRIL is a proliferation-inducing ligand. It influences B cell survival, differentiation, and immunoglobulin class switching, particularly towards IgA production. So if you inhibit APRIL, you can inhibit that class switching and prevent production of abnormal IgA antibodies. And that has been shown to be effective. Of course, if you have RPGN, then Cytoxin may be the best immunosuppressive agent to utilize. ACTH has been used in IgA nephropathy. It does reduce proteinuria without significant change in renal function and serum albumin, but it's probably a drug to use if others have failed. Let's talk about lupus nephritis. What is lupus nephritis? In lupus nephritis, you develop autoimmunity to nuclear components, specifically anti-nuclear antibodies, and a specific type of anti-nuclear antibody, which is antibodies to double-stranded DNA. You can have antibodies against complement components such as C1q. Lupus can affect any organ, but 60% of lupus patients manifest as lupus nephritis. It is more common in women with a ratio of 6 to 13 to 1. Mortality of systemic lupus erythematosus has decreased over the last 30 years, as has the incidence of end-stage renal disease, mainly because we're diagnosing it better and we're treating it better. There's a higher incidence in Blacks and Hispanics compared to European individuals, and the presentation has become less severe in recent years. There's an increase in patient age at time of diagnosis, longer time between diagnosis of lupus and development of lupus nephritis, and the presentation is with urinary abnormalities rather than renal insufficiency. So let's talk about kidney biopsy. How do you diagnose lupus nephritis? This is light microscopy, and so we'll go through all of the 6 classes. This is class 1, in which all you see is mesangial immune deposits, and those black deposits are black. So here's your mesangium, and you can see the black immune deposits. So all you see is a little bit of immune deposit, but no hypercellularity or influx of leukocytes. This is the earliest class of lupus nephritis. And then we'll talk about how classification of lupus nephritis alters the management of lupus nephritis. This is class 2, also very early in lupus nephritis. And here you have the immune complexes. And so you can see that there are 4 cells in this area of the mesangium. So you have mesangial cell hypercellularity, but no influx of leukocytes. And by that, we mean that the capillary is open. There are no inflammatory cells in the capillary. Again, also very early in lupus nephritis. Class 3 and class 4 are managed exactly the same. The only difference between class 3 and class 4 is that in class 3, less than 50% of the glomerulus is involved. So it's a focal process. And in class 4 lupus nephritis, more than 50% of the glomerulus is involved. So it's a diffuse process. And again, all these definitions for interpretation of kidney biopsies, focal versus diffuse, what's mesangial hypercellularity, what's endocapillary hypercellularity, all of that, they have been defined in the 5th talk of the 8 talks of board review. So here you can see that there's 5 cells in the mesangium. So this is mesangial hypercellularity. You have the immune complexes in the mesangium, and then the capillary is also full of cells. So you have endocapillary hypercellularity. So this is class 3, class 4. which is mesangial and capillary influx of leukocytes. And here you can see this is class 3, class 4 with subendothelial capillary wall immune complexes. So like I said, you have the podocytes here in the green, and then you have the gray basement membrane, and then you have the endothelial cell. So just under the podocyte, but above the basement membrane, from our perspective, that's where the subepithelial immune complexes would be, because the podocyte is the epithelial cell. And then to the other side of the basement membrane, you have these subendothelial immune complexes. So in this particular representation, you have mesangial hypercellularity, mesangial immune complexes, and subendothelial immune complexes, and you don't have endocapillary hypercellularity. So again, this is also class 3, class 4. Now here, you can see that here the green is the podocyte, and then you have the gray is the basement membrane, and you can see that there are immune complexes on both sides of the basement membrane. So you have subepithelial immune complexes, and you have subendothelial immune complexes. You have endocapillary hypercellularity, mesangial hypercellularity, and then immune complexes in the mesangium as well. So this is class 3, class 4 plus class 5. And class 5 is membranous lupus nephritis. And membranous, and we'll talk about this in the final talk of the board review series, which is the 8th talk. A membranous nephropathy is characterized by subepithelial immune complexes. And there are many reasons why you can develop membranous nephropathy. Lupus is one of them. This is class 5 alone, so you don't have class 3 or class 4 in this representation. All you have is subepithelial immune complexes. The mesangium is good. There's only one cell. There's a little bit of a mesangial immune complex in the mesangium, but this is basically class 5 membranous lupus. Class 6 is rarely seen on kidney biopsies because when a patient with class 6 lupus or the theoretical class 6 lupus presents to you, you know that this is a very late disease and you're not going to biopsy that patient. You're not going to immune suppress that patient. So at that point, it'll be CKD management and maybe guiding that patient towards end-stage renal disease or dialysis. So class 6 is rarely seen on kidney biopsies, and this class may eventually be eliminated from the classification. You can see an MPGN pattern of injury on kidney biopsy, but this is not a separate class of lupus nephritis. This is typically a pattern that is seen in class 3 or class 4 lupus. And the clinical significance of MPGN, membranoproliferative glomerulonephritis, will be discussed in board review talk number 7. Again, just cursory definitions for membranoproliferative would be that the membrane is involved, the glomerular basement membrane, and that there's proliferation. Again, these terms are defined in the 5th board review talk. What is proliferation, mesangial proliferation, endocapillary proliferation? What is glomerular basement membrane thickening or injury? So 17% of patients with lupus nephritis also have ANCA positivity. And we'll talk about ANCA vasculitis just after we're done with lupus nephritis. So ANCA antibodies are anti-neutrophil cytoplasmic antibodies. If you and ANCA antibodies can be antibodies to myeloperoxidase, MPO, or PR3. And 82% of these patients who have dual ANA and ANCA positivity have anti-MPO antibodies. These patients may be more severe in terms of impairment, kidney impairment at the time of biopsy, and they are more likely to receive Cytoxan or cyclophosphamide. However, despite the aggressive management, there is no significant difference in outcome. Here's the lupus nephritis chronicity score. Chronicity is important because if there's significant chronicity on kidney biopsy, the benefit of immunosuppression is not likely to be greater than the risks. So you want always to keep that risk-benefit ratio in mind. And if the risk is higher than the benefit, then you should consider not immunosuppressing the patient. So you're going to score each aspect of the kidney biopsy: endocapillary hypercellularity, fibrinoid necrosis, hyaline deposits, which is the wire loop lesion, crescents, and then interstitial inflammation, fibrosis, tubular atrophy. And then you're going to come up with a chronicity score. You're going to add up everything. If the chronicity score is 0 to 2, then the chronicity is low. So at this, if the chronicity is low, you'll be inclined to immunosuppress the patient. If the score is 3 to 4, then there's moderate chronicity, and there may be irreversible scarring, but there's still a significant amount of reversible disease activity. But if the score is more than 4, then the chronicity is high, and you should probably not immunosuppress the patient at that point. So now we go to management. Like I said, class 1 and class 2 is very early lupus nephritis, and at that stage, you are not going to immunosuppress the patient. If they have low level of proteinuria, then the immunosuppression will be guided by extrarenal manifestations. So you're not going to immunosuppress the patient because of class 1 or class 2 lupus nephritis. You're going to immunosuppress them if they have extrarenal manifestations, discoid lupus, malar rash, lupus arthritis, lupus serositis, and of course that management will mainly be guided by the rheumatologist. If you have class 1 or class 2 lupus nephritis with nephrotic syndrome, then you should evaluate for lupus podocytopathy and generally treat as minimal change disease, which would be maintenance combination therapy with low-dose glucocorticoid and another immunosuppressive agent. If the kidney biopsy shows class 3 or class 4 lupus, plus or minus class 5 lupus nephritis, then of course the first thing is to assess the chronicity. If there's marked chronicity, generally more than 50% fibrosis, then immunosuppression is likely not indicated and more harmful than good. If there's not that much chronicity and there's active class 3 or class 4 lupus, plus or minus class 5, then you are going to immunosuppress, which means you're going to do pulse solumedrol followed by oral prednisone, and the protocol is described here. And you're going to use one of these options. The option that I use most often is mycophenolate and calcineurin inhibitor. And the calcineurin inhibitor that we use is voclosporin, although you can use tacrolimus or cyclosporin. But tacrolimus and cyclosporin have a narrow therapeutic index, so you have to maintain that trough within a narrow range. So you have to periodically check the tacrolimus or cyclosporin troughs. Voclosporin doesn't need monitoring of levels. Um, so so it is a little bit easier to use, and but again, it is a calcineurin inhibitor, so it can be nephrotoxic, and it's generally not used for GFR less than 45 milliliters per minute per body surface area. And calcineurin inhibitor plus mycophenolate is also more appropriate if you have more proteinuria or a high risk. Belimumab is also a very good option. Generally, lesser proteinuria, lesser risk, less high risk than the calcineurin inhibitor. But belimumab is effective and can be used along with mycophenolate. Of course, the traditional treatment would be your mycophenolate, and then if you're were high risk in the past, cyclophosphamide or Cytoxan was the approach that was followed. Um, So what is complete remission? Complete remission is reduction in proteinuria less than 0.5 gram per gram or 500 milligram per gram. But these days, we would consider complete remission, or at least we would shoot for a goal of less than 250 milligrams. But less than 500 milligrams is consistent with complete remission. Of course, you want to have stabilization or improvement in kidney function. And this generally should occur within 6 to 12 months of starting therapy, but could take a little bit longer. Partial response is a reduction in proteinuria by at least 50% and to less than 3 gram per gram or 3,000 milligram per gram. As measured by the urine protein to creatinine ratio or a 24-hour urine collection. And you want to have stabilization or improvement in kidney function within 6 to 12 months of starting therapy. If there is no kidney response, which means you fail to achieve partial or complete response within 6 to 12 months, that is failure of therapy or lack of kidney response. For maintenance purposes, you want to reduce that prednisone to less than 5 milligrams per day, or maybe discontinue it. And then for maintenance, and you do need maintenance in lupus nephritis, the first choice is mycophenolate. If you used voclosporin, then you should continue with voclosporin and mycophenolate. And voclosporin is generally continued for about 2 years. In some cases, azathioprine may be appropriate, especially if they have GI intolerance to mycophenolate or other reasons. And then if you can't use mycophenolate or azathioprine, then you can maintain with the calcineurin inhibitor alone. If lupus nephritis is refractory, then what do you do? First thing to do always is verify adherence to treatment. Are they actually taking their immunosuppressive medications? And frequently, patients do not take their immunosuppressive medications. They may have nausea or diarrhea, and they may not tell you that they have these adverse effects. Some patients will reduce it to every other day or several times a week instead of on a daily basis. Some people will not take it at all. So you need to verify adherence. That may be why lupus nephritis did not improve. Second thing is ensure that the dosing of immunosuppressive medications is adequate. If you need to check plasma levels, then you can check the plasma levels. Mycophenolate levels can be checked. And then once those steps have been traversed, then of course you should biopsy the patient because at that point something else may be going on at the microscopic level. Either you have increased fibrosis and immunosuppression is not appropriate anymore, or some other process may be going on in the kidney biopsy. You can switch to an alternative agent, which is one of the recommended options. So if you're using mycophenolate, use Cytoxan. If you were using Cytoxan, use mycophenolate. And then if you even if that doesn't work, then of course you have lesser options at that point. But addition of rituximab may have some benefits, or an extended course of Cytoxan. ANCA vasculitis. ANCA vasculitis is a multi-system disease characterized by necrotizing inflammation of small and medium-sized blood vessels and autoantibodies to anti-neutrophil cytoplasmic antibodies, specifically myeloperoxidase, or MPO, and proteinase 3, PR3. So the disease processes that result are termed microscopic polyangiitis, which is generally caused by anti-MPO antibodies, or granulomatosis with polyangiitis, which is generally caused by anti-PR3 antibodies. You can also have eosinophilic granulomatosis with polyangiitis, or EGPA, and this is in patients with asthma and eosinophilia who also have ANCA antibodies. Renal involvement with pauci-immune glomerulonephritis is present in greater than 80% of patients with ANCA vasculitis. So again, on the kidney biopsy in patients with ANCA vasculitis, you're going to have pauci-immune glomerulonephritis, which means that pretty much you might have crescents or necrotizing inflammation, but you don't have immune complexes. Survival is now more than 90% at 1 year, due in part to improvements in immune suppression guided by therapeutic trials. So antigen-specific assays have improved sensitivity and specificity and should be first-line tests in patients with suspected vasculitis. So we no longer check non-specific ANCA antibodies. We check for specifically anti-MPO or anti-PR3 antibodies. Indirect immunofluorescence is no longer recommended as a screening tool. In patients with a negative antigen-specific assay and high suspicion or weak false positive, a second antigen-specific assay should be used to improve sensitivity and specificity. In approximately 10% of patients with a clinical diagnosis of ANCA vasculitis, ANCA testing may be negative and histologic diagnosis should be pursued. So there were 2 randomized controlled clinical trials that demonstrated non-inferiority of rituximab to cyclophosphamide in remission induction. So rituximab has been increasingly used either as first-line therapy or as an alternative in patients who are resistant or intolerant of cyclophosphamide. In patients with rapidly progressive glomerulonephritis or lung hemorrhage, consideration of plasma exchange has been recommended, and this is a KDIGO recommendation. But we'll talk about why rheumatologists are not emphasizing plasma exchange because of newer data regarding the efficacy of plasma exchange in altering outcomes. Outcomes have improved, but adverse events remain high. Mycophenolate was studied as a way of reducing adverse events, but this has not been borne out in studies. Mycophenolate may be non-inferior to cyclophosphamide in remission induction in patients with mild vasculitis, but relapse rates are higher. So on to plasma exchange. There was a trial called the PEXIVUS trial, which is plasma exchange and glucocorticoid dosing in ANCA vasculitis. Greater than 700 patients with moderate to severe renal impairment were randomized to plasma exchange versus no plasma exchange with remission induction with standard versus reduced glucocorticoid dosing and either rituximab or cyclophosphamide. So during a median follow-up of 2.9 years, plasma exchange did not have an impact on the composite primary outcome of end-stage renal disease or death. There were no differences in secondary outcomes, including death, end-stage renal disease, or infections. And there was no interaction with glucocorticoid assignment. There was a trend towards benefit in severe lung hemorrhage. Trend, not statistical significance. But there was no harm from plasma exchange in the trial. But if there is lung hemorrhage or rapidly progressive glomerulonephritis, KDIGO does recommend plasma exchange. Newer treatments include avacopan. Avacopan is a small molecule inhibitor of the C5a receptor. So as I mentioned, you would expect post-immune glomerulonephritis in patients with ANCA vasculitis, and this might be seen as an indication that immune complexes or complement is not important in ANCA vasculitis. But that's actually not true. Even though you don't have immune complexes and the role of complement may seem to be undermined by kidney biopsies. There is a role of complement in ANCA vasculitis, but that doesn't translate into what you see on kidney biopsy. And this is demonstrated by the fact that the small molecule inhibitor of the C5a receptor is non-inferior but not superior to tapered prednisone with respect to remission at week 26. So in the Advocate clinical trial, which was published in the New England Journal of Medicine in February of 2021, patients received rituximab or cyclophosphamide followed by avacopan or tapered oral prednisone. And as I said, avacopan was non-inferior but not superior to tapered prednisone with respect to remission at week 26. And avacopan was superior to tapered prednisone with respect to sustained remission at week 52. And KDIGO does recommend glucocorticoid taper or avacopan. So there is a role of complement in ANCA vasculitis, but frequently we don't see complement deficiency. We don't see low C3 or C4 in ANCA vasculitis or those immune complexes in the kidney biopsy. So Once you have a diagnosis of ANCA vasculitis, you want to have a disease assessment. Again, chronicity is important, although in ANCA vasculitis, chronicity is less important because it is a life-threatening disease. So even if the chronicity is high on the kidney biopsy, in the kidney, immunosuppression is still likely indicated uh, for um, for protection from mortality and poor outcomes, life-threatening outcomes. So if you don't have organ-threatening involvement, then you can use rituximab or plus glucocorticoid taper or avacopan, or Cytoxan plus glucocorticoid taper or avacopan. If you do have vital organ or life-threatening disease, then you should consider Ritux plus cyclophosphamide, or cyclophosphamide alone. But rituximab plus cyclophosphamide is increasingly being used and recommended if there's a vital organ or life-threatening disease. For disease control, you want to maintain with rituximab or stop rituximab and then monitor for remission. And if the disease recurs, then you can reinstitute the rituximab. If you use Cytoxan for remission, then you should switch to azathioprine. Immunosuppression should be extended for a period of 12 to 18 months. Like I said, if remission was induced with rituximab, then you should continue maintenance with rituximab. If remission was induced with cyclophosphamide, then you should switch to azathioprine at the 6-month mark. Then you have the main Ritson study, and patients on maintenance rituximab, nearly all relapses occurred in patients with positive ANCA or with repopulation of the CD19 positive B cells. So in the main Ritson 2 study, patients received rituximab 500 milligrams every 6 months, so maintenance, or only if CD19 positive B cells were detectable, and the study was over 28 months. The fixed group received 381 infusions, whereas the tailored group received 241 infusions. So you monitor the B cells, and if the B cells repopulate, then you infuse with rituximab. Or in the fixed group, you give rituximab regardless of the B cell status. The relapse-free survival was comparable between the two groups. Major relapse was very infrequent in both groups, and there was no difference in cumulative glucocorticoid dosage or adverse events. So fixed dosing is generally not used. We'll end this talk with a brief discussion of anti-GBM disease. Anti-GBM disease is characterized by the presence of directly pathogenic autoantibodies directed against well-characterized antigens in the MC1 domains of collagen 4 in the glomerular and alveolar basement membranes. This presents with rapidly progressive glomerulonephritis, diffuse alveolar hemorrhage, or both. Anti-GBM disease should be treated with plasma exchange, cytotoxic immunosuppression, and glucocorticoids. The KDIGO guidelines recognize that in the absence of lung hemorrhage, when 100% of glomeruli on the kidney biopsy specimen are affected by crescent formation, recovery from dialysis is so unlikely that treatment may be considered futile. But you may still be inclined to immunosuppress, but it's almost as if you don't expect remission or recovery in patients who have 100% of glomeruli with crescents. Also, patients with sclerotic class disease, more than 50% of glomeruli affected by global sclerosis, these patients also did not recover. So aggressive treatment may also be considered futile in these cases. Overall, the 5-year renal survival is about 34%. Nearly all patients, all studies with anti-GBM disease have shown that recovery in patients with early dialysis dependence is very low, meaning once the patient is on dialysis, recovery from dialysis is very low. "30 to 50% of patients with anti-GBM antibodies also have ANCA positivity." So again, this is another case of dual antibody positivity. These patients with both anti-GBM antibodies and ANCA antibodies display features of both anti-GBM disease and ANCA vasculitis. And some studies have shown favorable outcomes, whereas others have demonstrated equivalent or worse outcomes. High rates of diffuse alveolar hemorrhage and dialysis-dependent renal failure have been reported, and non-significant improved trends towards renal recovery has been reported in double antibody positive patients. Double positive disease may be characterized by relapses similar to ANCA vasculitis. Single positive anti-GBM disease patients do not experience relapse. So why do patients have dual anti-GBM and ANCA positivity? It's thought that some of these patients, the dual positivity is because of anti-peroxidase antibodies. Peroxidase shares sequence homology to MPO. So basically it looks like MPO. That's why one would develop anti-MPO antibodies. But peroxidase is essential for the quaternary structure of the basement membranes. That's why you have anti-GBM antibodies. So that peroxidase can give rise to anti-ANCA and anti-GBM antibodies, dual positivity. That's the end of this talk. Board Review Volume 7 will be Nephritic Syndromes Part 2, and we'll talk about MPGN and other remaining nephritic syndromes. And then Board Review Volume 8 will summarize nephrotic syndromes. And remember, all of my talks will be available at youtube.com/@irfanmoinuddin-kidney. See you next time. Enjoy your day.